is associated with low-grade inflammation, and this inflammation is associated with, in the coming time, renal or diabetic nephropathy. So CRP is an important inflammatory marker. Apart from inflammation, it is also a pro-inflammatory. What it does is it binds to CD32 or 64 and then stimulates MAP3. This MAP3 further then signals transforming growth factor beta, which we know that it is fibrosing factor. Thereby, CRP itself can lead to diabetic nephropathy in diabetes type 2 mellitus. What I've done here in terms of methods is we had a CBL here, and I've taken an fully automated biochemical analyzer, and I've used a method called as colorimetry enzymatic study for CRP along with random blood sugars. In terms of electrolytes, I've taken iron selective electrode method. What we came into conclusion out here was there is a significant difference in CRP and in case of CRP and random blood sugar in diabetic nephropathy when compared to type 2 diabetes mellitus. In the end, I would also like to conclude that it is important that CRP is to be done in type 2 diabetes to prevent the diabetic nephropathy in the coming time. Thank you. Today, in our particular lab, we are performing only plain CRP and not with respect to high sensitive. It is important to also do high sensitivity CRP testing there. It will be a much better option than doing plain CRP.
What is the duration of this study?
So I've done it for 3-4 months. Only I've taken only 30 cases out here of known diabetes, of known diabetic nephropathy out here, and I've compared
known cases of diabetes.
Yes, sir. Since I'm in biochemistry department, so I have cooperated with medicine department to collect known patients.
Any correlation with HbA1c, CRP?
Not in this case, sir. It would be a better idea, yes, sir. It would be a better idea since we do not perform in our lab HbA1c. I'd like to do that in the coming future as well.
So what message you want to give?
I want to tell to every since diabetes that's
because what we are doing is, you must be doing diabetic nephropathy, we are screening them for microalbuminuria.
Yes.
Do you want to replace microalbuminuria by say reactive protein?
I think since C-reactive protein has a direct impact on diabetic nephropathy by SMAD3 protein and then causing fibrosis in the kidney, I think I would suggest patients to also undergo CRP as a diagnosis.
So or only?
No, it's not the only one. I would also suggest other tests along with this.
What do you think that CRP will have advantages over microalbuminuria?
I think, sir, this is over this high sensitive CRP is much more better option than CRP since we do not have it in our CBL. I think creatinine is to albumin ratio is also a better option to do when compared to CRP as well.
No, creatinine albumin ratio. No. What all the main objective behind that
Yes, sir.
ratio, whether the sample given is really concentrated urine or just the
I think
objective.
yes. I think I would take. It depends on patients. If a patient concentrated to white pepper, then we would.
The early morning sample is always concentrated.
Yes.
First provided
Yes.
sample is always concentrated.
Yes.
But we want to check whether it's really early morning or not.
Yes.
Because sometimes, especially in the diabetic patients, they do have a frequency of urination, and especially if they are of older age,
Yes.
it may happen that they may void the urine early at 3 a.m. or like that. And by mistake, they will take after their sunrise as an early morning.
What was the duration of diabetes in all your patients?
It was 3 years, 4 years.
The
Yes.
minimum duration and maximum duration.
Maximum
in the study you
does-
included that?
Not in this, in terms of this week, but I did do a test for 10 years, approximately to where the patients stayed. They were approximately 10 years diagnosed.
Well, that will also make a difference because
Yes, sir.
long term only will result in
Yes.
immediately you can't.
Yes. So I've taken a known diabetes nephropathy in here.
Then already taken known
Yes,
cases
sir.
on here.
Since we, yes.
This can be taken as a pilot study.
Yeah, it's a
Pilot
better
study.
predictor as you say.
This can be taken as a pilot study, and we can extend it into the persons with early diabetes and follow them for a longer duration.
Thank you so much, sir.
Mechanical engineering.
And you are affiliated to Department of Zoology.
No, sir. So I am in mechanical engineering department, Dr. It's a central university called engineering.
Yes, and I believe it's Indian University.
ICT is a chemical. So my guide is recently joined, day before yesterday he joined as a registrar in ICT.
I see.
Otherwise he is in
How
Barcelona.
you got this conference?
So Dr. Sir has said me no idea about this. Because last week I was in IIT Bombay, similar conference where doctors and engineers are together working. So there are many technology. I'm from software background also. So here idea is 3D scanning, 3D printing technology for biomedical applications. So now recent technology can scan, CT scan data, convert into STL file and then directly print it. It will directly print either polymer or metal printing also. So I'm working, we have some printer available in our facility. So I'm working to convert that data into printed. So directly you can place those implants into the human body or animals. So that will help for getting exact customized data to either patient or animals who it is. So that's the whole objective here. And I was in US last 3 years where working with the JNTU, Biomet and all. So they have given what kind of technology or mainly the material combination is which material is ready 3D printable. So it took a layer by layer printing of the same shape, whatever shape you have, because our body parts are very complicated as compared to conventional. Today what is happening is like if you are fitting the hip joint, the head and aspect they have a particular size and shape. So for that, currently we are cutting extra bone to the patient. So it's a loss of extra bone to the patient. If we get scan the data and put the similar or print exact the implant.
How are you going to scan the?
So one is this.
For example, you will take that example you put it just now. Now, how are, for example, I am the case. How you are going to screen my goals first? And the data you are going to get from by which way?
Yes. So first method is like CT scan data I need to get. So it will give in the diagram format. And diagram format we have a software like Unix software. With that we can convert this data into STL file. And STL file you need to just clean something and that directly this is the software where we can clean some extra tessellated data, make it a proper shape, and then directly print it in this machine. So I already tried printing this. In fact, I am
How
doing
many
on.
cases you are doing?
Currently, I am doing my own case also and some animal. I tried.
Animal experience. How many
And,
animal experience you are doing? Which animals you are doing?
rat is mainly what focusing, and I got.
Right.
Yeah. So I got it from zoology department. My elder brother is working. He's pro vice chancellor for Solapur University. Is working here. So I got those animal scan data, which animal bone now. So and apart from that, I am trying on myself because I want to do
What exactly you are doing on yourself?
So I am trying to propose the technology directly scan, print, and right now if you are purchasing those implants from US, it's very costly. So my idea is like you make it with the lower price and also trying to avoid extra bone cutting to people or who are patients. Like second
person, if he wants to get his bone 3D,
Correct.
you can keep that and according to that you will make the implant.
Correct.
Customize
So
implant.
directly we are printing the bone implant and we are directly fitting into the human body. So it's a very fast way. Like if we want to do in the normal conventional way, it will take 3 months to 6 months. But if I scan the data by tomorrow I can fit the implant to the human body. So time, it's like future technology. I thought this is a trade going to
This
present.
technology is used somewhere else.
So it's currently used in the mechanical engineering domain mostly, like automobile part, aerospace part, because this large part that need to replace entire. So, but I need to correct only some portion. I can use this. Even I was in IIT last week, so Navy is also using for correcting some parts. Minor, those are very complex. I don't want to go for entire 6 month duration. So with this technology, we scan and print. It's like within 2 days I can.
Pregnancies in human beings being tried at states or in
Even outside
countries.
India.
Correct. Outside India, they are trying because there are many things. It's not only the implant, even medical medicine tab also. they create printing through this printing technology, and the tablet will release the content after periodic, whatever the intention we wanted to have. Like after 1 hour, I want to release this content and that. So entire day that medicine need to be fed to human. So these are technology evolving. So that's what I have seen in J&J and even Striker also in Florida.
Technology where lots of implants are used.
Correct.
Orthopedic surgery.
Yes. And apart from that, this data once converted, it will be a library. We don't need to know do further dissection animals and like killing them. So we can convert that into software. We develop this software also. In this software now we can open all the data, and you can now further take a section or check the measurement of dimension and all. So this data will be long term available for any students. We don't need to do similar. Yeah, data banking also we can use. And data is like, it's huge, like once it's created, it can be used. Even I can add a comment without going to any, visiting any other doctor or hospitals. I can directly add a comment, Dr. So he added this comment for this particular section of this portion. So this comments can be written into that library, and this is a huge library we can create for worldwide. So my focus currently here is bring this technology as early as possible to people in India, because dislocation of hip joints and other is a pain, and extra bone cutting is also a pain. What will be work as a working in a mechanical, but I can maybe some medical terms I am not familiar with, but trying my best to understand all medical terms.
Hemolytic uremic syndrome is a rare but severe condition caused mostly by infection and less likely due to genetic predisposition and underlying condition. Early picking of hemolytic uremic syndrome, varied etiologies and manifestations is important to improve the clinical outcomes. Hemolytic uremic syndrome is microangiopathic thrombocytopenia. It is characterized by triad of It is characterized by a triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney. Here I am presenting a 46-year female who presented in Markandeya Rugnalaya with the complaints of abdominal pain, nausea, vomiting, and loose stools. On history of presenting illness, she complained of abdominal which was crampy in nature, diffuse. She also complained of nausea and vomiting, 2-3 episodes, loose, non-biliary and non-bloody. She also had loose stools which were bloody in nature. There was no history of fever. There was no past history of DM, HTN, COPD, ischemic heart disease, or travel. There was no rash. She had high risk behavior was also not present. On clinical examination, she was a moderately built female with a BMI of 24.4. On examination, no pallas, anosis, clubbing, lymphadenopathy was present. She was vitally stable, BP 138 in supine position, pulse rate 89 beats per minute, regular rhythm, and saturation was 98%, temperature 98 degrees Fahrenheit. No significant findings were present on per abdomen examination, but there was mild distension and tenderness present. Laboratory findings on the day of examination, we did a routine CBC which showed an HB of 9, platelet count of 48,000, and WBC is 8,200. Creatinine was raised, it was 6.6, ESR 130, CRP 4.58. Electrolytes were not within normal. Serologically, she was negative for HIV, HBsAg, and SCV. On peripheral smear, she showed a fragmented RBCs. We did an EUG.
She is mentioned of the microcytic hypochondrial anemia, which is a very common observation in the blood conditions, isn't it? That will not point towards the hemolytic uremic HUS.
We did an EOG for her, which came to be raised echogenicity of kidneys, and the cortico-medullary junction was preserved. we did an stool routine microscopy which showed pus cells, blood, and on microscopy WBC is 8 to 10 powerful and RBC is 10 to 15 high power. Protozoa and cysts were negative. No organism with darting motility was culture sensitive came to be sterile. For thrombocytopenia we sent for dengue which came to be negative. We did another investigation site like ANA, PCT and DCT which also came to be negative. H3 and H4, C3 and C4 were on lower sides. Serum LDH were raised and retic count was also raised in this patient. Based on clinical history and laboratory finding, we made a provisional diagnosis of hemolytic uremic syndrome, probably atypical. Treatment with CVP guided fluids were given, steroids. The main treatment, mainstay, plasmapheresis, 5 cycles were done. With improvement in urine output, creatinine, and reaching a target of platelet count 150,000, we discharged the patient and patient was asked to refer to nephrologist. The take-home message from this case I want to highlight is that in adults, microangiopathic hemolytic anemia, we should have a high suspicion index of HUS, so that we can pick up the cases and we can avoid the end-stage renal diseases in these patients.
Do you think that end-stage renal disease may really occur?
Yes, in atypical HUS cases, sir, 40 to 50% of patients go in ESRDs.
All cases of hemolytic anemia will land up in this type of patient?
No, in a typical HUS, sir, most of these 99% patients are children. They get remissions.
There are 2 cases or 1 case? 46?
One.
46.
By mistake, it happens. 46 here won't be taken.
First and only one. Any other cases, any other literature you have studied? It's hemolytic anemia? No?
Yes, sir, I'm studying English.
What are how many cases we have recorded?
So the epidemiologist says we have in 1 million, 2, 3 cases are present.
1 million patients coming with
Yes.
How to suspect that this patient will?
A triad of bloody diarrhea plus raised creat and thrombocytopenia series. We should suspect
That is only criteria.
Right.
Shown the PS where the broken fragmented are these.
This. And this is a atypical HUS algorithm. Sir. Alternate complement pathway activates that C3, then C5, B9, which causes endothelial cells to cause more thrombotic angiopathy.
Any persons which are more susceptible to this type of syndrome, we should suspect that this person may land up in
Some of the genetic mutations, sir, such as CFDH, is there.
CFD. इसको मालूम है क्या?
Cystic fibrosis.
Cystic fibrosis.
Cystic fibrosis.
Thank you.
So,
You are attached to which department?
so Department of Radiology, Junior Resident, second year, VMGMC Solapur. Sir, 19-year-old male presented to our department with chief complaints of swelling on his right arm. On clinical examination, the mass was well circumscribed. There was no
Where was the location of my?
upper arm, sir, on middle aspect. There was no signs of inflammation present. On doing USG, solid cystic lesion was found. The initial first diagnosis was said to be lipoma. However, on further analysis, the diagnosis of peripheral nerve sheath tumor was made. So,
One question. You are talking about diagnosis of lipoma on your radiological examination
Not
or
medical
clinical
examination.
on radiological.
Now, what made you shift from the diagnosis of lipoma to nerve sheath?
So,
First question will be why you diagnosed it as a lipoma. Second question, why shifted to diagnosis of nerve sheath?
So the lesion was in subcutaneous vein. It was consistent. It's there also in intramuscular vein and
Monastery lipoma.
so no. Yeah.
No, what I want to say is, what were your findings at first time to say it's a lipoma?
So clinically they send the patient as lipoma.
अगर वो क्लिनिकली अगर श्योर होते हैं तो वो ऑपरेटिंग करते हैं, आपके पास क्यों भेजते हैं, है ना?
क्लिनिकल पिक्चर नहीं का पेशेंट क्लिनिकल
पण ठीक
पिक्चर
आहे. ते होतं त्याने शिफ्ट का केलं की
हां.
असे काय आहेत कंपाउंडिंग फॅक्टर्स which made you think of a lipoma, then ruling out those factors, you shifted to neural disease.
Sir, the
Nerve shifting.
yes. So the lesion was seen to be arising from the nerve.
Okay. This
So-
can you demonstrate the nerve?
Sir, yes. So this is tendon. The entire this is tendon, and this is the lesion. So the initial scan was done on USG, not ultrasound. So if you, it's not great discernible due to printed format, but it's arising from nerve only. So the second differential we had in mind was angiomyoma. However, nerve was easily discernible, so we diagnosed it as nerve shifting. So my talk is basically on how exactly, to answer your question, how do we differentiate it from other benign conditions such as lipoma and sebaceous. Yes.
Fibrosis too, sir.
Yes. So there are some classical signs. So first which I mentioned previously was entering or exiting nerve sign. If we trace the lesion from along its entire extent longitudinally, it can demonstrate presence of that the lesions are arising from the nerve. Secondly, there is associated muscle atrophy in the deeper plane. Then there is something called as target sign. This sign is not seen on ultrasound. This is seen in CT or MRI. So, sorry, only in MRI. On MR imaging, on T2 five-side imaging, there is a hyperintense lesion, and within that hyperintense lesion, there are multiple hypointense areas. This refers to the target sign. There's another sign, exactly opposite to this. There is something called as vascular sign. Vascular sign is peripheral hyperintensity, bright areas is seen, within which hypointense area would be noted. There is also T2 vascular ring, T2 peripheral ring sign. It's another synonym only for vascular sign. So these are the basic things which help us to identify that the lesion is probably of neural origin. And then now the task was to identify whether it's benign or malignant. It's completely not possible to say label it as malignant on imaging study. Still, there are some clues which help us to label it as benign or malignant. First is the size greater than 5 centimeter. Second is there is a marked perilesional edema. There is cystic degeneration within the lesion. On contrast administration, there is marked peripheral enhancement. So this points towards more malignant changes in the lesion. This way not some. It was benign in progressing towards.
Put some clinical pictures of the tumors post-operatively also.
Sir, this patient came to our hospital a couple of weeks back. So
What might operate?
no, and even HPR is pending, sir.
Operated?
No, sir.
How is this?
Sometimes they do pre-op biopsy if their patient is willing.
That's it.
Yes. And however, FNAC was done, sir. On FNAC, spindle cells were seen. So, sir, then again, this was we ruled out angiomyoma because spindle cells will not be seen in angiomyoma. So,
Label it right.
Remember on FNAC, any soft tissue tumor will have a spindle cell.
yes, sir. Yes.
Epilepsy just guides you what you are supposed to do, and in some cases epilepsy definitely tells you what you should do. I know sir. Epilepsy तुम्हाला फक्त गाईड
It will
करतो.
not tell you definitely.
हां,
Definitely
पण
diagnosis.
काही काही याच्यामध्ये मात्र डेफिनेटली देईल. फॉर एक्झाम्पल
Clinical
मेटास्टॅटिक
picture
नोड्स.
the poster would have been made more enhanced if you would have put a clinical picture.
Sir, this is not post-contrast study.
Clinical, not radiological.
Okay.
Patient ka picture. Or you can understand more. You can make the poster more appreciable. Whether any patient had any symptoms regarding the
No, sir. Sir, patient had only swelling, except for aesthetic purpose he had composed. Peripheral nerve sheath were usually present with nerve symptoms, neurological complaints, depending upon this location. Sir. This location was also peripheral, so it was good.